All right. Welcome, everyone, to our virtual global spine conference. I'm Wendy Gibbs, neuroradiologist from Barrow Neurological Institute. And actually, I'm one of the original virtual spine hosts from back in the day during COVID. It's been a long time since I've gotten to come here, but it's great to be back and great to be sharing this session with my friend and surgeon educator extraordinaire, Michael Galgano, who is walking from the OR as we speak. So
Hey,
what we're going
Wendy.
to do this week, Dr. Galgano last week showed some amazing infection cases, how you surgically handle these cases. And because he had a few that he didn't get to show, there are some other good ones that I'm really excited about. What we decided to do today was kind of split this a little bit. He's going to get to show the rest of his cases, the second half of the program. In the first half, I'm actually going to show you how we evaluate this from the radiology side. I don't know how often that happens now in this conference. We used to do this not infrequently. And if you saw my LinkedIn post, you see that I said that after medical school, when we go our different ways into training, whether it's radiology, surgery, whatever, we kind of lose track of each other. We don't really have in-depth knowledge of what the other specialties are doing. And I think that's vital for patient care. Sometimes we have like spine conferences or tumor boards, but even that's not, general education. So I think this is super valuable. And it's so great for me personally to learn from the surgeons about what they are looking for and what they're doing so I can make my interpretations and reports more applicable to what they need to know. So I will start. I'm going to show you this. I think our surgeons who are on here, both our co-hosts and the surgeons in the audience, they probably have a good grasp on the imaging. But if you're a trainee, resident fellow, and you can really understand the images of the tests you're ordering and explain it to your team, I think that really would make you very valuable. So maybe you'll learn a couple things if you're new to this. If I can advance my slides here. All right. So I'm going to start out with this case. This was a 56-year-old woman who I don't know, I think she kind of lived in an underserved community. She couldn't go to a hospital, she didn't want to go to the ER. She went to an urgent care with neck pain. She had had chronic neck pain, but in the last 2 weeks, it had been really increasing. She was having a lot of sharp pain and discomfort, I guess. I don't know the whole story because this was before she came to us. So this is to start the imaging evaluation with X-ray. So when you hear of somebody with chronic neck pain, you kind of think you're looking first for degenerative changes. And so X-ray, when we're looking at the bones primarily, that's what we would say, are we looking at this for end-plate osteophytes, loss of disc space height, listheses? But when we hear the acute on chronic, we know something has changed, especially if it's severe. So in that kind of a situation, we're also looking for something like, already, because that's the topic of this session, infection or something like cancer or something else, especially if she hasn't had any trauma. So in this case, X-ray, bones. Bones all look really good. Normal vertebral body height and alignment, normal disc space height, no advanced degenerative changes. So what's wrong here? What else can we see? So we see that she has abnormally thick prevertebral soft tissues, way, way too thick. One of the, I don't usually use these measurements, but kind of a rule of thumb is if it's thicker than the width of a vertebral body, I don't know if the surgeons use that, then it's too much. But just looking at this, you can tell it's too much. And very few things can actually cause that. And I actually, please tell me if I'm wrong, people on the panel, but I don't think anything actually but infection could cause this because a diffuse enlargement of the prevertebral space all the way down, not much that could be. So I'm going to go to the next slide here when she came to us. So I flipped the x-ray around. So it's in the same orientation as the CT. This middle figure, this middle picture right here, 3 weeks. You can see how much has changed. And so that's why these are vital to be able to identify early and treat early. So in that 3 weeks, she's already at this level at 3-4, got collapse of vertebral bodies. She's got a new kyphosis. She's got, kind of a retropulsion of this body into the canal, producing significant narrowing, probably even thicker prevertebral soft tissues. She's got that demineralization, the osteoclide activated resorption from the inflammation from the infection. Now, this was a kind of an older case from another institution, and when she came in, it was like the middle of the night. She could not get an MRI that night, but the surgery residents, wanted to get her teed up for surgery because they know this was going to be a significant case. And so I said, get a CT with intravenous contrast. And this is another reason I'm showing these pictures. This is kind of a point that I think is a good tip for anybody. I think some prominent radiologists agree with or disagree with me, But I think this works quite well. If you give intravenous contrast in the setting of infection or tumor, you can often see enough to make your surgical plan if you can't get the MRI. So in this picture here on the end, you can see the epidural phlegmon and the prevertebral enhancing tissue as well. So you know that this is going to be a pretty significant case with, I don't know, maybe even abscess. Here on the bottom, if you can see it, there is, it's actually covered for me by my pictures of the people, but there is epidural phlegmon and prevertebral phlegmon. One other point from this slide that I'd like to make that I didn't think of till right before I got on here because I was looking at this first slide is moving patients. Now, you all don't, or you all probably think about this because you are operating on them, but maybe for the radiologist, I was looking at this and there's even a greater kyphosis here than there was here. So the need to be safe when you're moving patients with unstable spines. Maybe that's for radiologists if any are watching. All right. So this is the MRI. So finally in the morning, she got her MRI. And I'm showing you these so you know what you're looking at when you order an MRI for infection. So this is a sagittal T1. These are the typical sequences we get in this exam. A sagittal T1, a sagittal T2, a sagittal fat-saturated T2 or STIR, and then a post-contrast fat-saturated image. So these are important to be able to recognize. Again, this will kind of, for the trainees out there, this will set you ahead of the crowd. How do you recognize what these images are? I would say these are the two most important, the fat-saturated T2 or STIR and the post-contrast fat-sat. So in a normal T1 weighted image or basic image, the vertebral marrow fat is bright, T1 hyperintense, as is the subcutaneous fat. So those are both bright, and CSF is dark. On your T2, you all know this, your CSF is bright. This helps you evaluate how much space you have in the canal, how much cord compression. In your STIR or in your fat saturated T2, and I won't get into the physics of it, but all the signal from fat is taken away from the picture. So the subcutaneous fat is now dark, and also the vertebral bodies look darker because all that marrow fat, all that signal is gone. So that really highlights fluid within the bones and prevertebral space, but mostly for the osseous structures. And then same kind of principle for the post-contrast fat saturated image. When we take out the fat signal, which is bright, everything, all the bones are dark. And then anything that's enhancing, is truly enhancing. You're not fooled by that intrinsic T1 hyperintensity from fat. It's all pathology. And here you have the axial post-contrast. Again, there is ventral epidural phlegmon, and then prevertebral phlegmon as well.
Wendy, can I ask you a quick
Yeah,
question
yeah,
before
yeah.
you move on with the slides? So, how do you differentiate radiologically from abscess from phlegmon? I see that sometimes they're used kind of interchangeably, and I'm just curious what your thoughts are about what's abscess, what's phlegmon, because it actually does have some element of surgical implications for us as far as the way that
Okay.
we kind of approach some of these cases and what we expect to find.
See, this is why this is so valuable, Mike, because I would ask you the same question. So what I was taught by, one of the spine experts actually was one of my attendings in fellowship, and I asked this question. He said, if you have all enhancement and no central non-enhancement, that liquefactive necrotic stuff, then that is phlegmon. That's the only difference that I know. Would you say that's the case? That's all I know about it.
Typically
It's
I would call this phlegmon. When it's
yeah.
abscess, it's usually, in my opinion, a peripherally enhancing capsule, and then you'll see this hypointense core. And I have a case in my case examples a little bit later that I'll show you guys that I was pretty convinced was abscess. But sometimes you can be fooled. And I think even though we like to be black and white with radiology reports, this is phlegmon, this is abscess. There's a lot of times where we'll kind of break into what we suspect is phlegmon and, we'll see like actually frank pus in there as well. But my suspicion is that most of what we're looking at here in the far right image, I think that that's just all like a thick rind of phlegmonous tissue. And it's actually very difficult to take off the dura. If it's an abscess, once you get into that pocket, it just egresses out, right? But something like this, it's not so easy to take off the dura sometimes.
Well, that's interesting. So when we learn about abscesses like in the neck for our ENT work, we have the early abscess, maturing abscess. And I just assumed it just got necrotic in the middle. Wouldn't that edge of the abscess still be hard to take off the dura? You're
It
saying
is.
phlegmon is, important
It
that,
is, but the goal is to not take every piece of it off, right? You
uh-huh.
want to decompress the cord, but you also want to get rid of the volume of fluid that's there because it's not really just a compressive mechanism that will get these patients in trouble neurologically. It's the fact that these patients will oftentimes have, venous congestion, and some of them, once they become paralyzed, if it gets to that stage, they'll develop essentially a venous infarct from inability to properly drain the cord from the infection. It's the same reason why we see IgA thrombosis in patients that have prevertebral abscesses in their neck. And I think conceptually it's the same mechanism with the spinal cord as well. But I've seen it both with phlegmon and abscess. In my experience, the abscesses tend to be a bit more virulent than a phlegmon does as far as causing a neurological deficit, unless, of course, you've got severe kyphosis and you've got very, thick phlegmon, like what you see in that far right image there.
And that's something, and you can tell me if this is right, because this is what I teach our trainees, is that, like you said, it's not just compressive effects, it's actually the vascular effects that are going to get this person's cord. So, like you said, the venous outflow obstruction, and then also, we're taught it's also like there's spasm, the arterial spasm too, of the little arteries that are being
Right.
inflamed by the adjacent
And
infection.
they're kyphotic as well, and they're kind of bowstringing their core. So there's probably three or four different mechanisms as to why these patients will get in trouble neurologically.
See how valuable this is? Learning. I'm learning. It's valuable
Absolutely.
for me. Okay. All right. So this just shows again kind of how fast this progressed. And this is what I try to emphasize to our trainees is you really need to be on top of this because it can go so fast. And who knows what would have happened to this woman if she hadn't come in. And maybe you all know. Dr. Galfano knows. But so they went ahead, the residents, did their work here. They had this, they took out that infected bone, put in this big corpectomy and front and back fixation. And I actually don't know how she did because I don't know if we ever saw her again. I certainly didn't. But
You probably never will, Wendy, because this patient population, they're usually one and done. So
yeah,
I try to be pretty aggressive with them up front because you may never see them again.
yeah.
I,
And so
whatever they did here is exactly what I would have done. I showed a case like
is it?
this last week, similar at C3, C4. I would have done exactly this. Come from the front, put them in traction, two-level vertebrectomy, and then back them up. So this is a beautiful construct.
What do you think of my intravenous contrast thing in the middle there? Do you like that?
I
Or
love
do
it. I think it's great. I actually, I've seen that before on CTAs, where if a patient will come
yeah.
in and they have a CTA, you'll be able to pick up on the fact that they have an abscess. I remember a few years ago in New York, we had a case like that. A patient had a CTA, they had a history of seizures, they had some, weird neurological presentation, and on the CTA, you could actually pick up that there was we suspected it was a big abscess that was there. He had had some esophageal injury several weeks earlier. So things were kind of adding up that this may be an epidural abscess before we actually were able to get the MRI. The other interesting point you made too was about the prevertebral swelling that you see in the X-ray. It's very obvious there, but I'll be honest, Wendy, it's not something I typically look at. We get upright X-rays in all our pre-op patients, but I wouldn't pick up on that just by looking at a plain X-ray. So that's a very keen point. We
Yeah,
kind of
that's
think of x-rays as all, it's just for alignments, but there's obviously more you can appreciate on this film.
That's why, yeah, and that's why I like to start with that one because actually radiologists too, they don't always look at that so carefully, and it is important, as you can see from this case. And if for any surgeons, other surgeons listening, don't order a CTA though. I mean, you can order CTA, but it is best seen if they do it right on the regular CT with contrast of the neck because of timing issues, because the contrast fills the vessels but doesn't always fill the soft tissues at that time of imaging for a CTA. But both will work if it's, especially if the timing's wrong. Anyway, order the CT though, but either one will work. All right, so spine infection, that's what we're doing in this conference on this. Multidisciplinary approach is very important. So from the radiology perspective, we have kind of two roles. As you know, we're the ones that will kind of tell you if you need to know what kind of test to get, especially if you can't get an MRI. And we interpret it, but also we are the ones that usually do the procedures. And I've heard from my colleagues here before that sometimes some places it's hard to get a disc biopsy. Everywhere I've worked has been, academic sites and stuff, so it's not, I mean, that is what we do, and we do it, as quickly as we can. But some patients aren't, don't need it, and so, call your radiologist to see what they think. We could, decide which technique is best, which sample is best, whether it's soft tissue, disc, bone, whatever. I won't go into that one this time because there isn't time. Oh, so which imaging test is best? I think we all go to MRI first. Although I have heard some dissatisfaction out there from surgeons who say you can't tell the difference between the active type 1, modic type 1 end plate changes in some cases and infection. And that can be very hard differential. And the frustration with that often leads to people saying, I want a different test. So in the nuclear medicine literature, they say that PET, which you see on the Mr. Z over there, PET can also help, although that is much harder to get, more expensive, and there's radiation. Not maybe it doesn't matter that much, but if your MRI isn't helpful or you can't get it, you can try PET. And again, I this is very unpopular opinion amongst radiologists, even people in my own group, but I like CT a lot. And I think these days our CTs are just as good. We have good quality CT, are just as good sometimes as MRI. On this first patient, that's different than the other two patients. This look is very suspicious to me. This isn't a typical degenerative look. There is probably like the Schmoll's note here, but just this pattern of demineralization just looks a little strange. I'd be suspicious, and if they asked me to biopsy that, I would. The other reason I'm showing that particular picture as another teaching point is that I was taught, everybody I think in radiology is taught, you can't have infection if there's vacuum disc. And I know now that's not true because I've multiple cases where we've actually gotten infection from discs that look like this. Anytime there's still some disc in there, it can be infected. And of course, the bone can be infected as well. So don't let the vacuum, the air in there dissuade you. This look right here. Have you been taught that, Mike? Have you heard that or no?
That if there's a vacuum disc, there cannot
Yeah.
be infection?
Yeah. Or is
No,
that not something you ever
I
heard?
was never taught that. And in my experience, I've absolutely seen many infections that have a vacuum disc for
Okay.
sure.
Okay. I was just curious whether that was just something for radiology. Because, yeah, all the people disagree with me. They say if there's a vacuum disc, can't be
I
infected.
think vacuum disc just tells you that there's motion within the interdiscal cavity, right?
Yeah.
That's all my appreciation of it is. Wendy, so what is that? So when we say vacuum
Huh.
disc, right, and there's air in the disc, what what is what is that substance? I've always been curious myself, and
I think that's still, and hopefully there's someone on who can give a better answer than me. I don't know. It's a mystery to everybody. So it's probably nitrogen, but and when there's the instability and it moves, it sucks it in. And then I don't think it's static when you like have flexion extension. The mystery is why does it look like fluid on MRI then? I don't know the answer. I might need to do further investigation and see if there's a new answer to this question because I think not many people know why it has different appearances or exactly what it is. But you do see air in discs, even when there are disc extrusions and protrusions, you can see air in them sometimes. Um, so it is just sucking in that nitrogen or air from the tear, from the annular tear fissure, I guess. Do you have a better answer than me? Or do you know?
no, I don't. I don't. Well,
I
I've
don't know.
definitely heard the nitrogen idea as well. So
I
whatever
don't
that
know.
means, I'm not sure what to make of that.
Is Galgano still or not Galgano, is Selby still on here? I don't know if Dr. Selby had to leave
I
or he's
bet
been.
Alex Mamagani knows because he knows
Is he
everything.
here? Is he sleeping?
I don't know. He hopefully he's
Okay.
sleeping. He was here last week and
We'll
he
ask
was
we'll
great.
ask Alex next time. All right, so let's move on here. This is just the sensitivity and specificity and like I said, the nuclear medicine literature says the PET is just as good. All right, so key features of infection. The best one is actually not in the disc or in the bone. It's actually that paraspinal and epidural inflammatory signal intensity within the tissues. So if you're trying to differentiate an active type 1, modic type 1 end plate change from infection, look at the soft tissues around it because that will not look inflamed when the spine is just a degenerative process or the active type 1 modic. It'll be thicker and in, phlegmony, maybe not even phlegmony, but just in T2 hyperintense from the fluid signal around. So that's the best, the best clue for you when you're trying to decide. It's this paper, which is a really good paper, older, but it's really good, says disc enhancement is 95% sensitive. In my experience, um, I've seen a lot of infected discs that are not enhancing. I'm going to show you some examples of that. For me, the T2 hyperintense fluid signal disc is the best. And that's in this picture, the second picture right here. So when we say fluid signal, this is actually a stir image of fat saturated T2. But you see that normal discs are T2 hyperintense. Here's its internuclear cleft. But what we're talking about here is fluid that is the same intensity as CSF. So that thing is going to be infected for sure. For me, that's the best clue. And plate erosions, as we know. And oh, this lost internuclear cleft, that was in this paper. And I, as a resident, I thought it was so cool knowing that. But then I found out later you can't often see internuclear clefts anyway in adults and not much higher than whatever, lower thoracic, something like that. But it's still in there. It's a good one. This is another, oh, is this the same one? This is, it might be, I don't know if this is the same one or not, but it's another example of the T2 hyperintense disc that's infected. So again, this one is a normal disc. It's T2 hyperintense. It's got that internuclear cleft, but here it's the same signal intensity as CSF, and that one was infected. Now for the disc enhancement, I wanted to show this because this guy had two levels of infected disc. This one is enhancing, but this one not really, maybe on each edge, but not a lot, but it was infected level as well. And then here's some more cases of this. This one is a fat saturated post contrast image. And so you can obviously infected. You can see there's enhancement within the bone. There's this is an epidural abscess because it's marginally enhancing, centrally non-enhancing. So epidural abscess there, probably down here too. But you can see there's no enhancement whatsoever in the discs. And maybe you just say that's osteomyelitis, but I think it's still discitis osteomyelitis regardless. Um, this one where I just showed you the fluid signal on the prior screen there, the same intensity as CSF, not really enhancing at all, although we know it's infected. And of course, that first case I showed you from CT, that one is obviously enhancing. The bones are enhancing, the tissues are enhancing, but there's no enhancement within the disc. Are you able to see this picture? I'm not because my pictures are covering it of the attendees, but are you able to see it, Mike?
I don't yeah, I can see what you're talking
Nothing's
about.
covering that for you. Okay. Well, I know
No,
what's in it, even if I can't see it.
no,
So,
I can see it.
good, good, good. Okay. So, what if we can't get an MRI? And this goes back to my point about the CT. So, this is just an interesting case. Um, so my prior job, so when we were on call by ourselves, and so it was a weekend call. The technicians called and said, "Be ready. This MRI is coming through. Neurosurgeon's going to operate as soon as this patient gets here because of the severity of the symptoms." I'm like, okay, I'm ready. And so I tried to look in their jacket, and they had pushed over this CT that had been done relatively recently. And I was looking at that, and I said, wow, that doesn't look so bad. It looks like a typical osteoporotic fracture up here in the thoracic spine. Retropulsion of the posterior superior end plate, it's flattened, it's got that osteonecrotic cleft under the end plate. So I thought, okay, well, we'll see what we get. When they got to the hospital, of course, they couldn't get the MRI. I don't know what was happening, but they couldn't get right in. So I said, get your contrast, IV contrast, enhanced CT. So we did this. And hopefully you can appreciate this. It's pretty subtle, but maybe you can see it on your screens. There's a line right here. So there are two different things. This, whatever is here above, and whatever here is below, those are different things. And the same thing on the sagittal. There's something coming down this enhancing line. So there is a collection in front pushing the cord back. So that was our cord compression. I was so excited. So yes, I don't even need an MRI. This is going to be, an epidural hemorrhage that's causing this guy's symptom, a hematoma. So I called the neurosurgeon. I told him, I said, go ahead. This is a compressive hemorrhage. And he said, yeah, that's what I thought. So we went in to operate. Well, then of course we got the MRI. And so it was already too late. They were already off to surgery, whatever. But we got the MRI, and here, I mean, I think they did the MRI and then they sent the patient, but it was too late to do anything else. But here on the T2, you can see indeed there was a collection, just like we could see on CT. And the intensity of this is not the same as the CSF. It's a little bit darker, and it is pushing the cord back. This one is our stir, our fat saturated T2. This one's really, the technique on this one makes it very dark, but you can see that the fracture was indeed recent. There's edema within that body, and you can tell the difference between this collection right here and the rest of the CSF and the cord being pushed backwards. Guy was in so much pain, you couldn't see anything on that axial image. So, I thought, okay, well, it's still right. We don't need to do anything different. Don't need to call the surgeon. Then afterwards, when the surgeon called me after the case, I kind of was thinking about it. I was so excited about it. I didn't even realize they hadn't sent the diffusion, which we got on all these cases. So I asked the techs and they sent me the diffusion, and that would have been very helpful for what the surgeon said. He said, "You know what, Wendy, I thought I thought it was going to be hemorrhage too. It was actually all pus. So this was a big epidural abscess. And the diffusion would have helped us with this because you can see there is diffusion positive signal here in the region of that abscess. So point is, you can get contrast enhanced CT If you want to see, if you look real carefully, you might get the answer, but also if you get an MRI, get diffusion if you can. Here's just another case we couldn't get the MRI right. We couldn't get the MRI at all because of a pacemaker at the time and couldn't get screened. And his high INR, we couldn't give him a myelogram. But you could see on this patient that we could clearly see that epidural abscess, big extensive abscess, just with the CT. Do you have anything, Mike? Anything before I move on?
I wouldn't have picked up on the fact that there was a multi-segmental abscess there. I figured that you were going in the direction of this pathologic fracture is likely an epidural abscess, hence the neurological symptoms, but I didn't expect that it would extend down that low. So
Yeah.
that's an interesting case though. But yeah, you have to have your antennas up with these cases, right? If they have a pathologic fracture and their neurological exam is obviously very out of proportion because when you first showed that CT scan, I'm saying this really doesn't look all that bad, right? It looks like an
Yeah.
osteoporotic compression deformity, and then they've got a 6-level epidural abscess, and that's why they're going paralyzed. So this is why
I
it's
would ask you, do
important
you know?
to examine patients, right?
Yeah. Well, I mean, both would have probably, yeah, the guy, nobody knew he was sick. I mean, he didn't have any indication that he would have an abscess. All his labs were normal and everything. I mean, he was a sick guy in
I
general.
don't think that matters. I've seen so many epidural abscesses and infections where they've got relatively innocuous looking labs. They
Okay.
might have like a slightly elevated ESR/CRP, but their white count's not 35, it's
Mm.
13 or 14, right? And they're not spiking incredibly high fever. So it's actually I would say it's the exception when you see a patient that has a white count that's absolutely through the roof with an infection. They usually it's almost like a smoldering infection that they have. But I'm going to show you a couple cases after where that's not the case, and I suspect I have my reasons why it's like that.
Okay. All right. Good. And by the way, you tell me too. I'm just going to tell me when it's halfway so I can stop and you can show your cases. Because with all the extra chatting, I don't want to run over so that you can't show yours.
No, you're
Um,
you're fine. We'll have
and I
time.
can't see. I can't see my clock. So. This again are some of the point. This is just highlighting some of the points I already made. How you can see a lot with CT. The point about you can have vacuum disc and it still can be infected, and that contrast can help us identify the kind of the degree of cord compression and epidural phlegmon. And this appearance, this unusual appearance of the end plates. Again, I don't think this is in any literature anywhere. But if you just look how unusual that looks, to me that looks. And this was infected, by the way, this appearance does not look degenerative to me. It's different than that. And so I don't know. Have you seen that before, Mike, or have you noticed it? You just see how it looks a little demineralized, but not like degenerative
Yeah,
changes?
I would have a strong suspicion that this is infected. Yeah, I mean, if it's degenerative, there's usually still a cortical rim around it, even though there's some erosion into the vertebral bodies. But when it looks like that there's loss of that end plate cortex, then that's when I get suspicious that there's an infection brewing.
You should write that up because it's not in the radiology literature that I know.
This is
Okay.
just all anecdotal stuff from
Anecdotal from,
years.
yes. Okay. X-rays, most, and really, and I don't think anybody uses this to diagnose, but, as you're tracking to see if they need surgery. That's what these pictures were for. So really you don't notice the changes till a little bit later in the subacute phase. I'm not going to talk about intervention today, but that's, call your radiologist and we can tell you about stopping or not stopping antibiotics and blood thinners and things like that. I'm going to skip over this just in the interest of time. Because I want to show this. Actually, there are just a few more I want to show, and then I'll have you go ahead, Mike. Successful treatment. What does successful treatment look like? So imaging findings lag behind the clinical improvement. And this is something I think you all know, but and yet we still always are getting orders for patients to get imaging pretty quickly after they started treatment to see if they're better. And we know that whatever we're seeing on the pictures is not really indicative of what the patient's status is. So, what are we looking for? The first thing when they're healing, the first thing that we look for to see if we know what successful treatment is a decrease in that soft tissue, the pre and perivertebral soft tissues that are inflamed, or any abscesses, and then reconstitution of the fatty marrow. So you remember these were two different scanners, so that's why they look different. But the marrow is T1 hyper intense. So when it goes from this T1 hypo intense, where this is all infiltrated with infection with watery cells, and starts to normalize normal vertebral body with fat again, then they'll get T1 hyper intense again on T1. So this was a case of that. This is just an example. I liked this case a lot. This is a 40-year-old, I think he was a construction worker. He had increasing back pain. He was a drug user. And he came in, very typical picture for discitis osteomyelitis. This is when he first came in. So sagittal T1, and like you said, Mike, he's lost those end plates, these black lines, which are so clear everywhere else. He's completely lost that. There's collapse. There's T1 hypointensity because the marrow fat's been replaced by those watery cells. On the stir, there's fluid signal within the bodies. Again, there's that collapse and starting to be deformity there. On the post contrast, there's epidural, maybe phlegmon, I guess, or maybe reactive dura, but probably a little phlegmon there. On the end plates, they're enhancing, and there is kind of some epidural enhancement or prevertebral enhancement as well, and on that axial. And then he came back because he was a good citizen. He was supposed to return in 3 months. We biopsied it. Sorry, I left out part of the story. We biopsied it. Was infected. I don't remember what the bug was, but they sent him out because he was a drug user. They didn't want to put him on the 6 weeks of IV antibiotics, I guess. They put him on oral Bactrim for whatever reason. I don't know if that's crazy, but that's what they did. So he went away. He came back for 3 months follow up. He felt totally better. His back was fine. They did his labs. His labs were normal, but they still got the MRI. And you look at this MRI, this is not the same picture. This is his follow up. He looks exactly the same. So there's the same degree of prevertebral enhancement, epidural, ventral epidural enhancement, and enhancement along the end plates there. And on the axial, if anything, the enhancement in the epidural space looks even a little bit more, but it's not. So his labs were normal and he felt fine. So really, they didn't do anything. They just sent him home, said, keep up the good work, whatever. So he was completely better, but the imaging lags behind. So don't feel like this is treatment failure, even though this really looks like it, right? And even though we tell people that, they still get the imaging. And you just don't want to act on the imaging. Act on the patient, like you always say. Act on the patient's symptoms and labs and everything else. Don't always trust the imaging. Oh, Aaron, is it 30? Because that is perfect timing if it is, because that was probably the last one I should show right now. What do you think of that, Mike? What do you think about that appearance? It's almost exactly alike.
Yeah, yeah, it's incredible. It really is.
So maybe it'll get better. It just takes more time. Or maybe it's the oral Bactrim and he's just pretending to be better. I don't know.
That's wild.
Anyway, I think if it's time, if it's halfway, I want to stop and let Mike you show your cases. Is that good?
Okay, sure.
Because yeah, the rest are kind of mimics and stuff, but we can show those another time. So I'm going to stop sharing my screen.
Let's see. See if you guys able to see my screen?
Yes.
You are. Okay. Let's see. Okay. So I'll go over some cases with you guys. A continuation of last week. And Wendy, I'd love your input for these from a radiographic perspective. So this was a lady last summer I operated on, and she was a transfer from an outside hospital out in Western Carolina. And she essentially she has a history of remote IV drug use from about a year and a half or so ago. She went to a hospital in Asheville, North Carolina, with complaints of really debilitating kind of mid to low back pain over the last couple of weeks. And she was starting to lose feeling in her legs. She began having urinary incontinence and it was quite weak to the point where she just could not ambulate anymore. She could still move her legs. She had about 3 out of 5 strength in her legs. But this is the scan that she went to the outside hospital about. And they called me and they said, Dr. Galgano, we have a patient that has, a spondylolisthesis at L5S1, and she's losing function in her legs. And they also had a CT scan. So, what do you think about this, Wendy? Does that quite add up?
Well, from this, I don't think then there was another case that I could have shown that'll go along with my point here is you see the signal abnormality, it's very well defined in the bones. So there's almost like a line here. So we wouldn't think of that as like an infected body.
Right.
Um, so that would be more like the active type 1 mode exchange, degenerative interchange.
Yeah, no, I agree. Yeah, I mean,
And yeah,
this
I
is a
don't see
lytic
anything else.
spondy. Yeah, so like when I looked at this, I said that I always tell my residents, look higher. If it doesn't make sense, look higher.
Look higher.
So they got a CT, they got an MRI scan at the outside hospital, and then eventually sent her to us, and this is what she ended up having. at, let's see, 5, 4, 3, 2, 1, 12, 11. So about 10 T10 or so. So what do you think about this? Does that explain her symptoms? Um,
So I'm trying to see it. I wish I could make it a little bit bigger, but it looks like you've got fluid signal, ventrally. You've got more diffuse fluid signal in this first picture in the body, I think.
are
This
you
is
able to see up higher?
up higher than the fracture.
No, at the fracture. So two separate issues, right? So she's
Yeah.
got a lytic spondy at 5.1,
Uh-huh.
which is why they called us. But then we ended up obtaining a thoracic MRI too, and we found
So
that she's got
T910.
this, yeah, now we've
Yeah.
we've got this T910 pathologic
Yeah.
fracture here.
Pathologic fracture collapse, and then you've got that triangle of fluid signal, right?
Right.
Very bright fluid signal.
Right.
And
And
mhm.
then we got a contrasted film as well. And sorry, CT scan first. And I thought we had a contra. Oh, here it is. Here's a contrasted film.
That, yeah. So that stuff in the big triangle of non-enhancing stuff is all dead tissue,
Right. It's
right?
all necrotic. Right.
And it's also interesting that the end plate below, we said that was 9, 10. So is that 11?
Right.
2, 1, 12 or 12, whatever. That it looks relative. There's some enhancement, subtle enhancement in that body that's retained its normal shape below. It's
Right. Yeah,
very
I see
subtle,
that. Yeah, I mean, you see that with infections all the time where they like to climb to their neighbors, right?
but
Um,
probably
be-
subligamentous climb, right? Since that disc is kind of dead. It's not
yeah,
going through
either
the
either
disc.
that or it's just through, the small arterioles or capillaries that kind of live
Yeah.
within the end plates of the vertebral bodies, and then they just kind of spread through that network or Batson's venous plexus, right? Because of the valveless venous system.
Hmm.
And this is what the
Well,
CT
Owen,
scan
can you go
was.
back for a second? Sorry,
Yeah,
Mike. That was the perfect example of that's how you know it's infected on that axial image, that paraspinal, prevertebral, paravertebral soft tissue.
right.
If there was any doubt, there's no doubt, but that is where you look if when there is doubt. So
Right.
sorry.
So this was what her CAT scan looked like beforehand. So she's got a couple of problems, right? I don't think she necessarily has a frank abscess based on this, but definitely has phlegmon. She's got kyphosis, and she's got that bowstring effect on her spinal cord. So this is a pretty significant problem. She wasn't able to stand by the time she got to our hospital, and she's got about 30 degrees of focal kyphosis here. So I don't know, are there any other surgeons on the call? I don't know if Selby or Mamagani's on. I'm curious what you guys would do here. It's obviously a surgical problem. So we decided to do a posterior VCR here. So kind of jump straight to the good stuff, which is where we've placed our temporary rods on the contralateral side, and we've done our laminectomies, we've done our pediculectomy, facetectomies, right now partial corpectomy, and we have an angle dissector that we're placing just ventral to the dura, and just like you would do a PSO, you have to make sure that you impact that posterior vertebral body wall, and that's essentially what we're doing here. So we're impacting that into that cavity, that T2 hyperintense cavity that Wendy was referring to. That's all that necrotic tissue. That's basically what we're tamping those bone fragments into. This is a different case, but this was published a few years ago, and we have really nice microscopic video as to what that looks like. And it's super important for the surgeons out there that you really dissect the posterior and longitudinal ligament from the anterior dura. Once you establish that plane, which is actually very tricky to do in these infection cases, then you can start passing your Woodson elevator and your tools, such as the PSL impactor, in the anterior epidural space, and then start impacting that into your corpectomy cavity. It is important in this case also to have temporary rods. That way you don't have spinal translation. Before we reconstruct the anterior column here, I always like to get my deformity correction first. I don't like to rely on the corpectomy cage to do the correction for me. So we'll do our compression on each side. Sometimes it's asymmetric. That's one of the issues that we see with spinal infections, is that you'll have asymmetry to the amount of disease, right? One side of the disc may look a bit more normal than the other side, and because of that, you'll oftentimes get these really bizarre coronal curvatures. So we'll try to do our compression distraction before the cage goes in. And then this is one of those expandable titanium cages. We fill it with bone graft. In this particular case, I don't believe that we cut the nerve root. I think that we were had a good enough working corridor here that we were able to put the cage in perpendicular to the spinal cord, and then we performed this 90-degree rotational maneuver. And then at that point, we provisionally tighten the cage so that it stays in an expanded position, which is what we're doing here. We bring fluoroscopy in, and then we can make sure that the end caps of the cages are matching the end plates of the vertebral bodies above and below. But it is important in these infection cases that if you're going to do a corpectomy, you want to make sure that you're landing on a relatively normal vertebral body radiographically, because if you don't, what will happen is that your cage will subside into the vertebral body above, or the cage will actually migrate because of the amount of asymmetry that there is to the end plate. So in a case like this, it really required us to do essentially a two-level vertebrectomy from the back, which is what we did. Now that the cage is in, we're able to put the ipsilateral rod in. In all of these cases that are akin to doing a three-column osteotomy, I always place a quad rod in there as well, which is what we're doing here across that three-column defect. And then as far as getting an arthrodesis, we do attempt to do that obviously in the interbody space through the cage. But I also like to use this essentially bag of this absorbable bag of cancellous bone. And what I'll do is I'll actually stitch it to the rod like this. When I trained with Zia years ago, we would do this, but with fibular strut grafts a lot. That could be a little bit more time consuming having to cut those to size. But I've had good success with these over the last couple of years I've been using these. So these are the intra-op X-rays that we had. This was a post-op this was a post-op CT scan, and she actually got a lot better in her legs. And she's probably about a year or so out of surgery now this past July. And she essentially regained a lot of movement in her legs, was actually back ambulating the last time I had talked to her in clinic a couple of months or so ago with a walker. So I think this was a nice outcome. These are actually very thankful patients um, once you get them all taken care of. And here's what her post-op x-rays look like afterwards.
Hey, Mike, before you go on to your next one, can I ask you a question about the
Yeah.
surgeon? When you use ca like the expandable cages like that, especially lower down, these people often have unhealthy bone everywhere, don't they? Like soft and not the healthiest
Yeah,
bone. And so,
absolutely.
do you ever use cement or anything else to kind of
Not an
prep, or
infection.
can you
No,
not?
for infection, and cement is actually contraindicated. At least that's what I was always taught. Because once bacteria infiltrates the cement, it's extraordinarily hard to eradicate. So I
So
tried very hard not to use cement purposely in these infection cases.
so how do you
Um,
deal with the soft bone or the unhealthy bone? Poor
You,
bone
you
quality.
do multiple pedicle screws above and below, like this construct. I think in this case we
Okay.
did three above, three below. For your typical burst fracture case that you do a corpectomy on, I would usually do two up, two down. But for a case like this, she doesn't have great bone, like you said, three up, three down, and then I'll usually quad rod across the construct as well, just to make sure that that we have some additional fixation here across that three-column osteotomy defect. And then you just keep your fingers crossed that these people actually fuse up and heal so that they don't fracture their rods or start pulling screws out. But this is a pretty robust construct that we did, so I have a low suspicion she's going to fail over time.
Okay. Because you
But
said your
you could
cases are
see. I mean,
generally not very healthy.
there is a little subsidence already, right? If you look at
That's
this.
kind of what made me think about it a little bit. Yeah. Okay.
Yeah. And what Zia used to teach me is even if they do subside a little bit, it's not a big deal because you've got pedicle screws above there. And I've seen many cases where it'll subside and it'll just rest on the screw, and the screw is made of titanium. And then at that point, the cage kind of stops moving, right? It's not your ideal post-op situation, but it's certainly not like a five-alarm fire that you have to fix, though.
Okay.
So this was a similar-ish type of a case, but I addressed it very differently, and I wanted to go over a pretty bad complication I had in this case, which I thought was unfortunate, but worth sharing with you all. So this was another similar demographic patient in her 50s, presented to us with severe back pain, neurologic symptoms, weakness in her legs, numbness. She had severe thoracic myelopathy, and here's what her CT scan looked like. Wendy, any thoughts about this one?
Again, the bones, it's obviously an infection case, but at the same time, you see that osteonecrotic cleft in the upper deformed body.
Right.
So it almost makes you think that that was already like kind of dying bone, like more of a chronic infection, maybe? I don't know. Acute.
Yeah, I think a lot of these infection deformity cases, they almost all are chronic,
Mm.
right? These patients, they don't really follow up with their ID doctors. Many of them, by the time they get to us, they've already been treated for osteo and discitis at some other facility, and then they just have poor follow-up. They're not compliant with their antibiotics, and then they come to us when they're going paralyzed and can't stand up straight anymore, right? That's kind of how a quaternary referral center works, like UNC. So I do believe this patient was actually treated for osteodiscitis several months earlier at another hospital. Here's our MRI scan.
Yeah, and it looks similar, right, with that kind of fluid signal and kind of dead tissue in there. Yeah,
Right,
it's
right. It
just the
looks
same,
awful.
right? It looks very similar.
It does. A completely different case, but similar. So I just wanted to go over a complication we had in this case. So this was a case I did very early on in my career, and we decided to do this all posterior. I think doing these posteriors is really a nice, reliable way. You could get your pedicle screws in, you've got full control of the spine, and you could do your PVCR, your posterior vertebral column resection, right? But uh, what you have to keep in mind is that uh, there's a lot of vascular anatomy adjacent to the spine, right? So obviously you have your aorta, your IVC, you've got your venous drainage that drains into the IVC. You've got your segmental arteries. And what ended up happening in this case is that as I completed the vertebrectomy on the left side, I was switching sides with my assistant, and my assistant was a bit overzealous. And when I started to get myself settled on the other side of the patient, he decided to place a pituitary rongeur and to kind of poke around and see if there was any residual disc or vertebral body that needed to come out, even though I had packed it off with essentially a cottonoid. And next thing I know is, Dr. Galgano, we have a bleeder. So I look down and there's a fountain of it's not venous blood, it's arterial blood that was pouring out, and we had a really bad problem on our hands. And essentially, what I suspect happened is that with the pituitary rongeur, which is a little grasper, he snagged one of the segmentals off of the aorta. And I think this is an important anatomical point to make about these cases is that this is not like a fracture case where you may still have a loss of integrity of the ALL, but the ALL is actually still intact in a lot of these cases, right? As in like a burst fracture. You may see disruption of the PLL, the flavum, but you'll still have some relative integrity of the ALL. But Wendy, what are your thoughts about the anterior longitudinal ligament in a case like this? Like it's got to be gone, correct?
Well, does it? I feel like in that third picture, it's too small for me to see too well, but is it, can't you still see a line there?
I mean,
Or is it
I guess
disrupted?
you can, but in my opinion, the integrity of the ALL here is really not robust, right? There's severe kyphosis, so just right there alone, the ALL is probably going to become a lot more lax
Okay.
now that you've got kyphosis there. And on this image, to me, it
Yeah,
just doesn't look like that
that
there's great
image. Yeah.
continuity of it, right? So essentially, where I'm going with this is that when you have a case of osteomyelitis this severe, especially with this, necrotic cleft, as Wendy described, right? Um, you have to be very careful as a surgeon dissecting in the anterior vertebral body space, right? You're not really protected by a nice, robust intercolumn of cortical bone. You're not protected by the interlongitudinal ligament. So if you put your pituitary rongeur in too deep, you can very easily snag the aorta, the IVC. If you're up higher, the esophagus, the azygos vein. There's a lot of badness that you could grasp. So what ended up happening was that we had a massive hemorrhage intraoperatively, and kind of a good trick for the trainees and other faculty out there that I had learned years ago from Chris Ames from UCSF, listening to one of his lectures, is that you can actually get these bleeds under reasonable control if you use something called bioglue. Bioglue is actually meant for cranial surgery, but what it does is it acts as it's a fibrin glue sealant, but it almost petrifies what it encapsulates. So we had it packed off, and I was able to inject bioglue in there after about an hour, hour and a half of trying to see, what was actually hemorrhaging. And it's impossible because you're looking into a black hole. You can't see anything in there. We even tried to bring the microscope in. It was very difficult. So I injected some bioglue. We packed it off. And unfortunately, the patient did develop a pretty large, hemopneumothorax and ended up requiring a chest tube. And then once we got her stabilized, we were actually able to take her back to surgery. And this is what her x-rays look like in between stages. And then we ended up taking her back for a staged transthoracic corpectomy, where we essentially finished taking out what vertebral body we hadn't gotten access to. And then we came in through the side of the chest. And then we were able to place a large footprint expandable cage here. So I think this just shows these are very, very dangerous operations to do. And that point Wendy and I were talking about with that vertebral body necrosis, the loss of integrity of the ALL, that screams red flags there. You have to be very, very careful when you dissect. When I do a lot of these cases now, I like to use navigation, specifically for understanding where I am within the vertebral body, so that we can obviously, God forbid, avoid a complication like that. Thank God she ended up doing okay long term, but this was someone that we very easily could have lost on the table if we didn't get this under better control.
Hey, can I ask you a question while you're
Yeah,
pausing for me?
absolutely. This is what
That
a
is,
post-op
when you
CT
said
looks
she
like.
just needed a chest tube, that to me seems like a pretty good outcome for that case. I'm glad it turned out that well because it,
Yeah,
of
it was
course,
pretty
that, right?
scary. This was probably the most anxiety-provoking surgery I've ever been a part of in my entire career. And I
Wow.
do a lot of wacky stuff. This was very anxiety-provoking, right? Because we're not, we deal with spinal cord neuromonitoring issues when we take tumors out. Like I'm used to that. We're doing scoliosis corrections. You get a little ditzel of a motor change here and there. That stuff doesn't really scare me, but when you've got big red bleeding or one of its neighbors and it's in a deep hole that's several centimeters that you can reach and you don't know what's bleeding, that's a pretty scary situation to be in that fortunately we don't find ourselves in very often.
Well, let me ask you about the ALL because that was one of your teaching points. So maybe it's okay if I ask about that.
Yeah,
In this
absolutely.
situation, so it's not trauma, it's not like it's torn. And I thought, a lot of infections travel under the ligaments, including the ALL. So
Right.
I thought, at least in the acute phase, they can't disintegrate, eat through the ligaments because they're too tough. So what is the mechanism of the ALL incompetence or whatever it is in this case? Is it just
I think it's really the kyphosis is what does it,
it's
like
buckled?
yeah,
It's
I think because they're so kyphotic there, you don't have any tension of your anterior longitudinal ligament. Right?
okay.
It's like the opposite of ligamentataxis. Ligamentataxis, you try to distract, right, to tighten up to make the PLL more taut. In this case, it's the opposite. By creating kyphosis, you're creating laxity of the ALL, right? It's kind of buckling on itself. And so I think that's essentially what makes it incompetent. And I'm sure
Okay.
that having, infectious material there certainly doesn't help the integrity of it as
Especially
well.
chronic. Yeah,
Right. Right.
that's really interesting. That's not something I'd ever thought about before. So thank
Yeah.
you.
I'm gonna I've got other interesting deformity cases, at least one or two others, but I do want to show I want to show some other wacky cases in the last 5 minutes here, some unusual spine presentations. This is really what I wanted to get your take on because this case threw me for this case was very perplexing to me. And I did this case just a few weeks ago, actually. This was a guy in his 70s who had I think it was a benign mass in the back of his neck in the retropharyngeal space. Years ago, one of our ENT surgeons took it out. It was like an angiomyolipoma or something. And either way, uncomplicated surgery. The guy returns back to the hospital with like a raging infection, blood culture's positive for some oral bacteria, strep viridans, I think it was. And he ended up having a pretty large retropharyngeal abscess and it was being treated with antibiotics. He actually needed to be trached and pegged. And at the time of his hospital course here, this was the initial CT scan that he had. So I think it's pretty obvious he's got, prevertebral collection. Wendy, I'll let you jump into kind of what you see here.
Well, again, he has that osteonecrotic cleft like you see in osteoporosis, and so maybe I don't know if you get that in chronic infection as well. I didn't think so, but that right under the subjacent to the inferior end plate
Right. So
five.
he went from being fully ambulatory in the hospital and then being discharged to rehabilitation to essentially having pretty brisk onset of upper extremity weakness to the point where he couldn't use his phone anymore. He was having to ask his family members to text his other children for updates. And then this progressed to very severe lower extremity weakness. So he got transferred back to our facility. At this point, I had never been consulted on the patient. So the medicine
Right
team
where
just,
your arrow is that a fracture? Or is that just dehiscence or ALL destruction there? It looks like he's a little bit too kyphotic at that level of your arrows, right?
right,
And his
right.
head is definitely.
So this was his
Yeah.
T2 MRI scan that he had. And this was his contrasted film. So what are your thoughts about
Wow,
this?
that's yeah. So both of those bodies, that's that is the post. So then no disc enhancement really, but ventrally there's that enhancement that's probably eaten through.
This is the enhancement. Sorry, this is the
Oh,
T2.
yeah, that's a
And
stir, right? Yeah.
yeah,
And
yeah, I
so
think
he
this is
has
the
got,
stir. And then
mhm,
this is the T1 with contrast.
which is another nice case of no enhancement in the disc because that's not where it's coming from. It's coming like from the retropharyngeal space, like you said, right?
Right,
And so he's got that abscess lower, which is interesting, but it's probably all infected. It's just the abscess that's lower, right? And then, yeah, a lot of cord signal all the way down. Oh,
right,
my abscess all the way down.
right. So what are your thoughts about this? This is at like the
Wow.
level of about T1 or T2. What are your thoughts about the axial? This is an axial T2 on the right and to the left
Oh.
sagittal T2.
Is that subdural empyema?
Yeah. Yeah,
Yeah,
so this is subdural.
super
So
rare, right?
this actually I have to say the radiology reporting actually helped us out tremendously here. I can think on one hand how many intradural infections I've seen. And, we just knew when we looked at the scan and we examined the guy, he was basically a quad. He was going quickly paralyzed. We knew we had to take this guy to surgery, right? So I looked at the scan real quick. Okay, yes, retropharyngeal abscess, osteodiscitis, epidural abscess. This is a home run. We have to take the guy, unzip his spine, and drain the abscess, right? But I always do look at the radiology reports, even though I like to make my own interpretations. I always read the radiology reports as well, and they read this as subdural abscess, and it actually got me thinking, like, shoot, are we missing something here? And when we got into surgery, we did our multi-level laminectomy, and we were able to take down some of the medial facet joint. And I popped into the ventral epidural space from a posterior approach. I didn't want to go through the neck. The neck was a treacherous, and we got some pus out, but the volume of abscess that we drained was really not that significant. So we brought the ultrasound in. I unfortunately don't have it with me today, and there was definitely a very bizarre appearing, picture with the ultrasound. It didn't look normal. I use ultrasound a lot in all my intradural cases. And if you look closely at the contrasted MRI scan, this was actually a subdural empyema that he had. So when you think about kind of the pathomechanics as to how that happens, we have to think about prolonged epidural infection. Some type of enzymatic degradation may take place of the dura from a bacteria such as Strep viridans, Staph aureus. You can also track along the dural sleeves of the nerve root because the epineurium becomes very thin. This is kind of like an anatomical weak point. And then it can also track through for septic thrombophlebitis as well. And then on a very rare occasion, you'll actually see a subarachnoid extension. So I'll jump to the video through this and kind of show you what we found. So uh, here we are. We're about to open the dura. Okay, so the dura is now opened, and you can see the arachnoid does not look right. It's glistening, and as we open that dura, you're going to see frank pus that's draining out. And this is not just a subdural space. This is actually a subarachnoid abscess, right? And once we saw this, we knew that this was very, very poor prognostically because once it reaches the subdural or subarachnoid space, this thing can just track up and down the spine. And, I suspected this guy had a poor prognosis. And unfortunately, he ended up not doing well clinically. We were unable to salvage any neurological function despite our best efforts. So, an impressive scan, interesting learning case, but from, a clinical outcome perspective, we did everything we could. He unfortunately just did not do very well from a neurological perspective. So, have you ever seen something like this, Wendy? It's
No.
pretty impressive case,
Yeah, I know I've never seen that before. I just know that's what it would look like, but I have never seen one in real life, and certainly
right?
these surgical
But
patients.
but this was a great case where the radiologist helped us out tremendously because it kind of raised our antennas that, hey, we should probably look intradural. And I'll be honest, when I looked at the first scan, I didn't pick up on that nuance lower down. I was just thinking, oh, this was kind of a run-of-the-mill epidural abscess. So interesting case. Um, I'm not going
Yeah.
to go over these for the next 10 minutes. I just wanted to show you guys that there are intramedullary abscesses as well. This was a case I took care of back in New York years ago. I think I showed this on Virtual Spine probably like 3 or 4 years ago. But this was an intramedullary spinal cord abscess. And Wendy, you had talked about the diffusion scan, right?
Mhm.
So this was kind of a funky looking clinical picture. We got a diffusion scan. We said this has got to be an abscess. And we ended up taking this patient to surgery, and we opened up the dura, we opened up the pia, and obviously found an infection there. Um, and this patient
Oh,
actually did phenomenal.
you
Uh,
just drain it and sew him up and he's
yeah,
okay?
we drained it. Closed her dura. She went on antibiotics, and she regained all of her strength back on her right side. She actually had right side hemiparesis. This was her follow-up scan, completely gone. Companion case to this, unfortunately, was a much worse case. This was a gentleman who actually had this was right around the pandemic, had a basal ganglia abscess, as you can see here, and then also concomitantly had a spinal cord abscess. This guy went from exercising every day, very fit 65-year-old guy, to just completely crashing neurologically, basically became a quad very, very quickly over the course of about 8 or 10 hours. We did not know exactly what we were dealing with here because IDIM abscesses are super rare. So we were actually treating this like it could be a tumor. We were doing D waves, neuromonitoring, all of that. And you have to see how forcefully this abscess came out of this patient's spinal cord. So here we are, we're going through the PIA, and look at the force with which that abscess egressed out as soon as we went through the PIA monitor there. So this is a very unfortunate case. This guy did not do well, despite our efforts to completely drain this intramedullary spinal cord abscess. After surgery, he ended up having migration of further abscess up north. The basal ganglia abscess got a bit larger, and he ended up passing, unfortunately. And sad case to end this virtual spine on, Wendy. We've got to end on a
Yeah,
better
it
note.
is.
But either way,
But yeah, the
interesting
rest was
case,
it.
though. It's just good to have on our differentials. Have you ever seen any of these subdural empyemas or like an intramedullary
I've never seen
abscess?
a subdural empyema. I maybe have seen one intramedullary abscess ever. Because that's
Yeah,
so
so
rare.
wacky cases, but I wanted to share those with all of you guys. We see a lot of infection cases here at UNC, and a lot of them turn into these very interesting deformity corrective cases. And then once in a while, we'll see one of these intradural cases. So I think that's all we have for time tonight, Wendy. It was
It's
awesome.
too bad. I want to see more. But yeah, it was so
I
Mike, I
know.
know so many of these now you've gotten published. And maybe you showed some of those. Maybe can you share them on LinkedIn with people who are watching now and in the future who watch this
Yeah,
after
yeah, absolutely. I
on
think that
our
would be cool.
website
Yeah,
and
so
stuff?
maybe what I'll do is in upcoming days, I'll share some of the publications that we've had. Myself and a few of our medical students and residents wrote up a whole case series of all a few cases we have of these intradural abscesses a couple of years ago that was published, and we've got, the full-length videos. So again, these are not common things you see in your practice, but it's good to keep in the back of your mind every once in a while. You'll come across a patient like this in practice, and you'll save their life, right? If you think quickly and you can evacuate these abscesses. So, as always, Wendy, I learned a ton from you. Thanks for
Oh,
hanging out tonight. This was great.
yeah,
And
thank you.
Amna, thank you for your help too. I'm not sure what we have on tap for next week, but I'm sure it'll be great.
Yeah,
And
Emma, do you know what we have next week?
Yeah, we have Dr. Selby next week.
Dr. Selby. All right, great.
it'll be Mike's crazy deformity cases,
Yeah.
volume 8.
All right. Well, good. Well, thanks again, everybody. Thank you, Mike Galgano, for those fantastic cases and the videos. And we'll see you all next time.
All right, guys. Great to see y'all. Thanks, Wendy.